My name is Prasanthi Gandham. I'm one of the pediatric endocrinologists, and I'm going to be speaking to you all today about hypophosphatemic rickets. And so without further ado, we'll get started. Okay. So today during this talk, we will be reviewing phosphate metabolism. We're going to review the pathophysiology of hypophosphatemic rickets. We're going to review the clinical manifestation of hypophosphatemic rickets and discuss the management. We'll start with a little bit of background. Rickets is a disorder of childhood that occurs due to a defect in bone mineralization, which then leads to abnormalities of the epiphyses. It primarily impacts the long bones, and in children, it presents with growth retardation and bone deformity. It may be due to defects in calcium, phosphorus, or vitamin D. In adults who have had fusion of their epiphyses, of course, in the setting of these defects, we typically see osteomalacia, which is a generalized softening of the skeleton due to defective bone mineralization. Clinically, those affected have muscle weakness and bone pain. In children, rickets commonly presents with osteomalacia. So historically, rickets has been divided into two primary groups, which would be calcipenic rickets and phosphatemic rickets. To this day, and historically, nutritional vitamin D deficient rickets has been the most common cause of rickets worldwide. But there are many other causes of calcipenic rickets, which include just dietary deficiency of calcium, malabsorptive disorders, lack of sunlight exposure. And in terms of phosphatemic rickets, you can, of course, have just dietary phosphate deficiency, but there are also a number of heritable forms of rickets that cause both calcipenic and phosphatemic forms. In calcipenic rickets, you can have mutations in the vitamin D receptor, which cause what used to be called vitamin D resistant rickets. There is also vitamin D dependent rickets, which occurs due to 1-alpha hydroxylase deficiency. And in terms of phosphatemic rickets, you can have X-linked dominant, autosomal recessive, and autosomal dominant forms of hypophosphatemic rickets, as well as hypophosphatemic rickets with hypercalciuria. And we will go through all of these different types of rickets as we proceed through the talk. So let's go back to medical school and talk a little bit about phosphate metabolism. About 85% of our total body phosphate is found in the skeleton. The remaining 15% are found across many other tissues in the body. Of course, phosphate is essential for a number of cellular functions. It's a constituent of DNA and membrane lipids. It's also seen in a number of high-energy phosphates and second messengers, such as CAMP and inositol triphosphate, amongst many others. And protein phosphorylation helps regulate a number of different enzyme and receptor activities. There are a variety of transporters, hormones, proteins that are involved in phosphate metabolism, including parathyroid hormone, 1,25-dihydroxyvitamin D, FGF23 plateau, which is FGF23's obligate co-receptor, and the sodium-dependent phosphate co-transporters. So let's dive into this a little bit deeper. The regulation of phosphorus by endocrine and paracrine factors is regulated by both intracellular and extracellular phosphate. The principal hormones that are regulating renal phosphate handling are parathyroid hormone, which is, of course, produced by the parathyroid gland, and FGF23, or fibroblast growth factor 23, which is produced in the bones by osteocytes and osteoblasts. In healthy individuals, an increase in serum phosphate concentration induces the secretion of both PTH and FGF23. And these two hormones, which are both phosphaturic, then reduce the expression of the sodium-dependent phosphate co-transporters 2A and 2C, which are expressed in the proximal renal tubules. The reduction in the expression of these co-transporters diminishes phosphate reabsorption and increases urinary phosphate excretion. PTH, of course, also increases 1-alpha hydroxylase in the kidney, thereby increasing production of the activated form of vitamin D, which is 1,25-dihydroxyvitamin D. And it also enhances intestinal calcium and phosphate absorption. There's some evidence that PTH induces expression and secretion of FGF23, And then FGF23 in turn decreases 1,25-dihydroxy vitamin D production, which is then an inhibitor, which is of course an inhibitor of PTH production. FGF23, as I mentioned before, is secreted by osteocytes, typically in response to activated vitamin D. The activated form of vitamin D increases mRNA expression of the genes that encode FGF23. FGF23 typically mediates its action in the kidney through binding to an FGF receptor, klotho complex, which then downregulates the sodium phosphate dependent co-transporters in the proximal tubules. It's important to note that even small changes in the plasma FGF23 levels are associated with pretty significant changes in urinary phosphate excretion. PHEX is a gene that encodes an endopeptidase, which is expressed pretty profusely on the surface of bone and teeth. The bony expression is localized to osteoblasts, osteocytes, and to odontoblasts, and so loss of function mutations in PHEX typically is going to result in X-linked dominant hypophosphatemic rickets, which we'll talk about in a little bit more detail. But this causes defective mineralization of both bone and the teeth. And PHEX also plays a major role in renal phosphate handling by suppressing FGF23. The sodium phosphate co-transporters type 2 are encoded by a gene called SLC34A, and that's going to be important as we talk a little bit more about specific types of hypophosphatemic rickets. So of course, phosphate metabolism, like most things in endocrinology, is regulated by a complex set of negative feedback loops. So when one has hypophosphatemia, there's a number of various clinical features that are seen. Typically, the symptoms of hypophosphatemia are due to intracellular phosphorus depletion. In the setting of hypophosphatemia, you have low 2,3 DPG, which results in a decrease in the release of oxygen to the tissue. And this is due to the increased affinity of hemoglobin for O2 in low DPG states. You also have impaired ATP production, resulting in inefficient and impaired cellular function. And so as a result, common presenting signs of hypophosphatemia are muscle weakness and fatigue. When there's acute and rapid drop in phosphorus levels, this can precipitate respiratory dysfunction, hemolysis, rhabdomyolysis, or cardiac failure. With more chronic or indolent hypophosphatemia, rickets and osteomalacia develop. It's important to note that infants and children typically have higher serum phosphorus levels, and so age-appropriate reference ranges should always be used to avoid missed or inappropriate diagnoses. Let's talk about the pathophysiology of rickets. Typically, longitudinal growth is determined by the activity of the growth plate cartilage located in the epiphyses of the long bones. The chondrocytes in the proliferative zone of the epiphyses divide quickly and organize themselves parallel to the direction of the growth. Some of these cells then become hypertrophic chondrocytes, which subsequently apoptose or transdifferentiate into osteoblasts. The apoptosed chondrocytes leave large empty lacunae, which are then invaded by blood cells and osteoprogenitors to produce osteoid, which then becomes mineralized. Low serum phosphate is actually the primary defect that results in rickets in all forms of rickets, both calcipenic and phosphopenic rickets. And this is because the low serum actually inhibits the apoptosis of chondrocytes and leads to accumulation of the hypertrophic chondrocytes. Eventually, this causes abnormal growth of the cartilaginous epiphyseal plate, and this results in many of the clinical manifestations and bony changes that we see in the setting of rickets. So there's a number of skeletal findings that we see in rickets. You can have widening of the metaphyses, craniotabes, which is essentially a softening of the bones of the skull, the ricketic rosary, which is due to enlargement of the costochondral junction, and it becomes visible as sort of a beating along the anterolateral aspects of the chest. You can also have formation of a Harrison groove that's seen at the lower margin of the thorax, and it's caused by the inward pull on the soft and lower ribs, by the diaphragmatic attachments. And you also, of course, have progressive lateral bowing of the femur and the tibia. You can have dental hypoplasia. And pathologic fractures can be seen in the setting of rickets, but you can also have pseudofractures, which are called looser zones. These are pathognomonic for osteomalacia or rickets, and they are typically identified on radiographs as sort of narrow radiolucent lines with sclerotic borders. And again, this is a characteristic finding seen in the setting of osteomalacia. Something that we'll see as we move forward through the talk is that many of the clinical manifestations, including the skeletal findings seen in rickets, vary somewhat depending on the actual underlying etiology of rickets. And so your skeletal findings can sometimes help you, I guess, make a prediction about what you think the actual underlying etiology is of hypophosphatemic or calcopenic rickets. So let's talk a little bit more about X-linked hypophosphatemic rickets. This is the most common cause of heritable rickets, of heritable hypophosphatemic rickets, I should say, with a 1 in 20,000, with an incidence of 1 in 20,000 live births. It accounts for about 80% of cases of familial hypophosphatemic rickets. It is transmitted in an autosomal dominant fashion. Many X-linked conditions are X-linked recessive, but this one is X-linked dominant. What's interesting is that the gene dosage effect that is oftentimes seen in a number of X-linked conditions is not clearly evident in the setting of XLH. And so this means that hemizygous males who will have a similar degree of hypophosphatemia as heterozygous females. And so as a result, everyone, no matter what type of presentation they have, is going to have a similar degree of clinical severity or bony changes. It's caused by inactivating mutations in FEX. And of course, FEX's job is to cleave FGF23 into its inactive form. And so this mutation in FEX leads to an increase in the amount of circulating FGF23, which in turn induces phosphaturia. The type of FEX mutation may play a role in determining the phenotype. And so what I mean by this is depending on whether you have a nonsense mutation or a missense mutation, the clinical phenotype might vary. But having said that, the severity of disease and the specific clinical manifestations oftentimes vary even within families. So family members who have the same mutation are not necessarily going to have identical presentations in terms of severity of disease. In addition to the mineralization defect due to hypophosphatemia, there is actually an intrinsic osteoblast defect that also contributes to bony disease in the setting of XLH. And conventional treatment, which is typically with phosphorus and calcitriol, has no impact on this osteoblast defect. And so you don't typically have or expect to have complete resolution of bony disease, even on patients who are adequately treated with conventional treatment. Interestingly, in the setting of XLH, craniotabes and the rachitic rosary are not typically seen. Usually the first or the most common initial finding seen is frontal bossing. This can present even in infancy, typically by about 6 months or so. There are also progressive limb deformities that develop as children become ambulatory. The limb deformities often can also cause an abnormal gait that I think is probably best described as a waddling gait. Lower limbs tend to be more severely affected compared to upper limbs, again, thought to be due to the effects of ambulation. And you can see a number of different types of limb deformities, including coxa-vara, genovalgum, and genovarum. There are frequent dental complications that are seen. You can have abscess non-carious teeth, enlarged pulp chambers, enamel defects, and disproportionate short stature. In adults, presentation is often with short stature, bone pains, pseudofractures, and enthesopathy, which is inflammation at the site of tendon or ligament attachments. On biochemical evaluation, you typically see, of course, a low serum phosphorus, a normal calcium level, normal or slightly elevated PTH due to the downregulation of PTH by FGF23, a decrease in renal tubular absorption as calculated by the TRP or the TMP-GFR, which we'll talk about moving forward. And of course, you have an increase in FGF23 levels and a low or inappropriately normal calcitriol level, 125 dihydroxyvitamin D. And conventional treatment, as I mentioned, is with phosphate and calcitriol replacement. So these are just some pictures of some of the findings that we see, clinical findings that we see in XLH. So you can see the young man in the top left-hand corner, he has gene the young lady in the middle of the picture has what's called the windswept deformity. This is a young lady who was not treated for her hypophosphatemic rickets. It was a late diagnosis, and so she has much more severe limb deformities. The picture of the arm and the hand, you can clearly see the widening of the metaphyses. And sometimes you can also see dolichocephaly, which is a cranial deformity where the head is disproportionately long and narrow. And this is because there can sometimes be alterations in the timing of when the sutures in the skull are closing. Let's move on to talking about autosomal dominant and autosomal recessive forms of hypophosphatemic rickets. In autosomal dominant hypophosphatemic rickets, there's a heterozygous mutation in the FGF23 gene, which is located on chromosome 12p13. The FGF23 molecule is mutated at the cleavage site, and because of this, PHEX is not able to cleave the mutated molecule, and you have higher concentrations of intact FGF23 in circulation. There's two subgroups in terms of clinical presentation. You can have a childhood onset autosomal dominant HR, and this is typically a more severe form and mimics very closely the findings that we see in XLH. Or you can have adolescent or young adult onset autosomal dominant forms, which typically presents with bone pain, weakness, and pseudofractures, but not the same degree of limb deformities that you see in XLH or in the childhood onset form. In autosomal recessive hypophosphatemic rickets, this occurs historically, it was thought to occur due to a loss of function mutation in DMP1, but we are now identifying more mutations that can also be transmitted in autosomal recessive form. So this is not the only type, just the most common or well described, best described. The DMP1 is a non-collagenous bone matrix protein. It's expressed in osteoblasts and osteocytes. And it essentially has roles in osteocyte proliferation and FGF23 downregulation. And so these loss of function mutations ultimately are going to result in increased FGF23, circulating FGF23. More recently, like I said, we've discovered more mutations that are transmitted in an autosomal recessive form. So ARHR2 is due to mutations in ENPP1. And ENPP1 generates an inorganic pyrophosphate, which is an inherent inhibitor of calcifications. When you have a deficiency in ENPP1, you have insufficient pyrophosphate, which leads to vascular calcification, but it does not cause concurrent increased bone mineralization. Instead, you have an increase in FGF23, which ultimately is going to result in hypophosphatemia. The generalized arterial calcifications that are seen will present in infancy most often, and they're lethal in about half of the affected infants. But we typically see hypophosphatemia developing in those who survive, and eventually the hypophosphatemia goes on to result in rickets and osteomalacia. The clinical and biochemical manifestations in general are similar to XLH. They too have a significant dental phenotype. So hypophosphatemic rickets with hypercalciuria occurs due to a loss of function mutation in SLC34-3A, which encodes the sodium-dependent phosphate cotransporter 2C. And so mutations in this cotransporter result in phosphaturia. Patients will have a low or low normal FGF23 level. So this means that this is non-FGF23 mediated hypophosphatemic rickets. The activated vitamin D is appropriately elevated for hypophosphatemia. Hypercalciuria is present, and this is thought to be secondary to the increased calcium absorption occurring due to the upregulation of 125 dihydroxyvitamin D. The predominant clinical manifestations are hypophosphatemic rickets and osteomalacia. But of course, because of the hypercalciuria, you can also have nephrolithiasis and nephrocalcinosis. And typically treatment is going to be with phosphate replacement alone. Because of the elevation in the activated vitamin D, giving calcitriol would just worsen the hypercalciuria and increase your risk of renal disease and nephrolithiasis. Now we're moving on to some of the acquired forms of hypophosphatemic rickets. Tumor-induced osteomalacia is an acquired paraneoplastic disorder in which phosphatonins are produced by tumor cells and ultimately resulting in phosphate wasting and rickettic or rickettic changes or osteomalacia. It's most commonly implicated in tumors that are benign mesenchymal tumors, most often of the long bones, but they can be tumors seen in other areas as well. The tumors are oftentimes slow growing, and so an indolent presentation is very common as far as any bony changes. But you can present at any age with bone pain and muscular weakness, and typically there's a definitive cure provided by surgical removal of the tumor. Even though hypophosphatemic rickets is most commonly due to an isolated renal defect, it can sometimes be associated with more generalized proximal renal tubular dysfunction. So Fanconi syndrome presents not only with renal phosphate loss, renal phosphate wasting, but you can also have glycosuria, hypokalemia, hyperuricosuriasia, generalized aminoaciduria, and proximal renal tubular acidosis. And there's a number of different etiologies that can cause Fanconi syndrome, such as cystinosis, Lowe syndrome, or Fanconi-Bickel syndrome. And treatment of the underlying etiology is what's going to result in a resolution of the phosphate wasting and prevention or resolution of rickets and osteomalacia. The patients with end-stage renal disease have severe FGF23 elevations. FGF23 starts to rise quite early in the setting of CKD, perhaps by stage 2. And FGF23 oftentimes starts to rise even prior to PTH. Initially, the rise in FGF23 is thought to be protective because it's increasing phosphate excretion, preventing hyperphosphatemia that can be seen in the setting of CKD. FGF23 is also, of course, going to downregulate your calcitriol level and downregulate PTH. And this is, of course, going to further increase your phosphaturia. However, as renal disease progresses and the number of functional nephrons decrease, the FGF23 is no longer able to enhance phosphaturia as efficiently or sufficiently. And this is thought to be due possibly to declining klotho expression, and eventually phosphate levels begin to rise. The rise in phosphate further is going to increase your FGF23 levels, and this ultimately results in off-target effects, primarily left ventricular hypertrophy and aortic calcifications, which can significantly increase morbidity and mortality in patients with end-stage renal disease. Even after transplant, FGF elevation persists, and this can result in long-standing hypophosphatemia and eventually rickets and osteomalacia. There's a transient hypophosphatemia that's also seen in the setting of hepatic transplants. Previously, it was thought to be FGF23 independent, but more recently, they found that in the setting of acute liver injury, liver macrophages have increased gene expression of the FGF23 gene. And they've also seen in infants with biliary atresia who have hypophosphatemia, there was resolution of the hypophosphatemia status post-transplant with normalization of FGF23 levels. There are also a number of more rare causes of phosphatemic rickets. In the setting of fibrous dysplasia, which can be either monoostotic or polyostotic, you can actually have hypophosphatemia because many FD lesions produce FGF23. Of course, depending on the amount of disease burden you have, you're going to have more severe hypophosphatemia. So those with polyostotic disease are much more likely to have clinically significant hypophosphatemia than those who have monostotic lesions. Excessive use of phosphate binders can cause hypophosphatemia. And then there are also some case reports of infants who have been exclusively given amino acid based or elemental formulas having decreased phosphorus levels and even skeletal changes consistent with rickets and osteomalacia. And so this is just a table to kind of summarize all of the different types of heritable and acquired forms of hypophosphatemic rickets that we've already discussed. Just thought it would be a nice thing for people to have and refer to, but we won't go through all of it again. So in a patient who you suspect has rickets just based on their physical exam or radiographic evidence, lab evaluation that you should obtain includes, of course, complete metabolic profile, magnesium levels, phosphorus, vitamin D, both the 25-hydroxy and 125-dihydroxy vitamin D, intact PTH, and urine calcium, phosphorus, and creatinine. And if you don't already have them, you can certainly get x-rays of the wrists and lower extremities. Always it's important to remember that nutritional rickets and other calcipenic forms of rickets must always be ruled out before you can really have a high degree of suspicion for hypophosphatemic rickets. And the main reason for that is because all the different forms of rickets, no matter whether they're calcipenic or phosphopenic, typically are going to present initially with low phosphorus levels. So once you have ruled out phosphopenic rickets, then and you start to evaluate for the possibility of hypophosphatemic rickets, one of the most important things you can do is assess essentially whether there's renal phosphate loss. And you do that by calculating either a TRP or the TMP-GFR. So approximately 80% of filtered phosphate is reabsorbed in the proximal tubule, and less than 10% of it is reabsorbed distally. As your renal phosphate load increases, your renal reabsorption of phos is also increasing. Eventually, your filtered rate of phos is going to reach a maximal tubular reabsorption rate, and that is the TMP, while your tubular reabsorption of phos is the fraction of phosphate in your glomerular filtrate that is reabsorbed in the renal tubules. Because your TMP is dependent on renal function, the TMP-GFR is the best measure of the actual renal tubular phosphate reabsorption. A low TMP-GFR in spite of low serum phosphorus is indicative of renal phosphate wasting, and this calculation is typically made after obtaining a serum fasting phosphorus and creatinine level and a second void urine sample. So I really like this little diagram that kind of walks us through how to evaluate for hypophosphatemic rickets and how to break down what you think the most likely diagnosis is. Again, the caveat is that you always have to rule out calcipenic causes of rickets, such as vitamin D deficiency, before you would undertake this evaluation. But if you have a low serum phosphorus level, first thing you're going to do is calculate your TMP-GFR. If it's high or normal, then you're looking at a possibility of impaired dietary intake, possibly using an amino acid-based formula if you have an infant, especially a premature infant, malabsorptive condition, phosphate binders, or if it's more acute, possibly something that's causing a transcellular shift like DKA or refeeding syndrome. If the TMP-GFR is low and you know that there's renal phosphate wasting, then the next step would be to obtain an FGF23 level, activated vitamin D levels, and assess the calcium. If your FGF23 is high, and you have a low or normal activated vitamin D level, and especially if the calcium is normal, then ask about family history. However, even if family history is not present, then likely you need to consider genetic causes. If there is a family history present, however, then you're most likely dealing with either X-linked dominant hypophosphatemic rickets or one of the autosomal dominant or autosomal recessive forms. If there's no family history, then things like tumor-induced osteomalacia, fibrous dysplasia, post-renal transplant, all these different things become more likely. And of course, just overall clinical presentation and the history is going to help you to better differentiate. If you have a low FGF23 and you have a high 125 dihydroxyvitamin D, then we're of course thinking of one of the non-FGF23 dependent forms of hypophosphatemic rickets. If the urine calcium level is high, if you have hypercalciuria, then likely this is either HHRH or a diuretic. Or if you have high urine calcium, but there's a number of other defects like glucoseuria, proteinuria, et cetera, then likely you're dealing with Fanconi syndrome. This is a similar algorithm, and I just included it, again, for reference for the future. So how do we treat hypophosphatemic rickets once it's been diagnosed? The treatment goals in children are to improve growth, improve rickety changes, prevent skeletal deformity or improve them if they're already present, prevent bone pain, increase muscle strength, and improve ambulation. In adults, we're aiming to decrease bone pain, heal any fractures that are already present and prevent ongoing fractures, and of course, improve mobility. Conventional treatment, like I said before, is with phosphate and calcitriol replacement. Typically, you're giving oral phosphorus 20 to 60 milligrams per kilogram per day. This is elemental phos divided into 3 to 5 doses. So as you can imagine, adherence to this regimen would be quite difficult for a lot of families and lots of individuals. We also are giving calcitriol 20 to 30 nanograms per kilo per day divided into 2 to 3 doses. The dose is titrated based on lab findings, skeletal deformity, and improvement in rickets, but we know that we're not correcting the underlying defect. And so renal phosphate wasting is not corrected. You don't expect your TMP-GFR to improve necessarily. We don't typically target normal serum phos levels either, and this is because of the increased risk of nephrocalcinosis and hyperparathyroidism, as well as significant GI distress that can occur with that amount of phos replacement. Typically in children, if you have adequate treatment, then you can improve growth, you can improve the lower limb deformities and prevent, progression of those deformities. But it's important to note that many of them will still go on to require corrective surgeries on their lower limbs. Giving the phos replacement without calcitriol is of course ineffective, and it can cause severe secondary hyperparathyroidism. So of course that should be avoided. These medications have a very short half-life. They require very frequent administration. And so adherence to their regimen is an obstacle for many affected individuals. For patients who have non-FGF23 mediated hypophosphatemic rickets like HHRH, again, we only use phosphate salts and not activated vitamin D due to the presence of hypercalciuria and the risk for progressive kidney disease. Fortunately, we now have more treatment options available, and that is burosumab. So burosumab is a fully human IgG monoclonal antibody. It binds FGF23, thereby preventing FGF23 signaling. While the conventional treatment with phos and calcitriol can improve bone mineralization, burosumab is better able to address the actual underlying defects in renal tubular phosphate reabsorption, and it can also increase your activated vitamin D production. So in clinical trials, burosumab was also shown to improve the severity of rickets, decrease bone pain, decrease stiffness, and improve physical functioning. In adults in particular, it's also been shown to improve fracture and pseudofracture healing. So burosumab has been approved for use in adults and children 1 year of age and older who have XLH and also, I think, TIO. The medication is given subcutaneously. It has a half-life of about 13 to 19 days. And so in adults, it's dosed once every 4 weeks, and in children, once every 2 weeks. The peak increase in the TMP-GFR after administration of the medication occurs about 7 days after the injection is given. The peak serum phosphorus and calcitriol levels are about 3 to 7 days after injection. And this is just helpful in terms of knowing when you might want to monitor labs to assess response to therapy. Calcitriol levels oftentimes rise into the supraphysiologic range after the first several injections. But in clinical trials, there was no hypercalcemia or hypercalciuria noted during the clinical trials. And typically the magnitude of the rise in the calcitriol lessens over time. And eventually levels will kind of plateau out into the physiologic range. For those that are on conventional therapy who are being transitioned to burosumab, you want to discontinue phosphate and calcitriol supplementation about 1 week prior to starting the medication. So as far as the dosing regimen is concerned, for children, we start at a dose of 0.8 milligrams per kilo every 2 weeks and titrate to a max dose of 2 milligrams per kilo every 2 weeks. In adults, the starting dose is of 1 milligram per kilo every 4 weeks with a max weight-based dose of 90 milligrams. The goal is to achieve phosphorus levels in the low normal to normal range. So again, this is unlike what we are doing in conventional treatment, where we're typically not expecting the phosphorus to rise into the normal range. That is the goal with burosumab. In randomized controlled trials, treatment with burosumab showed a number of significant improvements. So in children aged 1 to 12 years old who have active rickets and who are treated with conventional therapy for a mean of about 3 years, they were then randomized to either continue with conventional therapy or to start burosumab for about a 64-week controlled trial period. In those children, burosumab improved the fasting serum phosphorus and the TMP-GFR, but conventional therapy did not. Both treatment groups had improvements in rickets severity and alkaline phosphatase, but the improvements were greater, statistically significantly greater in children who were treated with burosumab. They also saw similar improvements in rickets among the children who were less than 5 years old and in those who were 5 to 12 years old at the time of enrollment. There was a modest improvement in growth seen in children on burosumab, but because the trial was only 64 weeks long, we don't really know what the effect is in terms of final adult height for those treated with burosumab. In adults, there was a 24-week randomized double-blind placebo-controlled trial in adults with XLH and chronic pain, and it demonstrated improvements in serum phosphorus. Bone turnover markers increased, and there were improvements in pain, stiffness, physical function, and mobility. At baseline, about half of the patients in both groups had active fractures or pseudofractures. After burosumab, about 43% of the active fractures or pseudofractures had healed completely by week 24, compared to only about 7.7% who had full healing in the placebo group. So certainly significantly improved. Of note, dental abscesses and periodontal disease remains the same in patients who are both on conventional and therapy and burosumab, which I thought was very interesting. But I expected there would be some improvement in dental health, but not really with burosumab. And as far as any side effects of therapy are concerned in pediatric trials, fever, myalgia, and transient injection site reactions are the most common complaint. Hypersensitivity reactions were fairly common, but certainly not severe enough that anybody withdrew from the trial. Other reported effects were headaches, cough, pain in the extremities, nasopharyngitis. And some people did report an early increase in bone pain at the time of initiation of therapy that eventually improved over time. In adult trials, there was an 11.8% incidence of restless leg syndrome in those treated with burosumab, compared to about 7.6% of those treated who were treated with the placebo only. But overall, well-tolerated therapy. As far as monitoring of therapy is concerned, in both conventional therapy and when using burosumab, oftentimes it's recommended to start with monthly labs, and then once stable dosing is achieved, you could space the labs out to every 2 to 3 months. And you'd want to check phosphorus, calcium, alkaline phosphatase, urine calcium, urine creatinine, and urine phos levels. In conventional therapy, hypophosphatemia, again, is not an indication to adjust the phosphorus or calcitriol dosing. But in burosumab, we do target a low normal trough phosphorus level. And the ALP is not used to titrate therapy. In both cases, whether you're on conventional therapy or burosumab, if the serum phos is elevated, then the dosing should be decreased. And then, of course, worsening kidney status or the presence of nephrocalcinosis or nephrolithiasis should also prompt a dose decrease. If there's hypercalcemia present in a patient on conventional therapy, then you would decrease the dose of calcitriol. And it's recommended that PTH levels be monitored at least once every 6 months. And if it's elevated, in those on conventional therapy, you would consider increasing the calcitriol dose or decreasing the phosphorus dosing. So in conclusion, hypophosphatemic rickets represents a set of rare disorders with both genetic and acquired causes identified. The clinical presentation may vary somewhat based on underlying etiology. Many long-term complications are seen in affected patients, which can result in diminished physical functioning and overall reduction in quality of life. Recently targeted therapy with burosumab has become available, leading to improved outcomes. And many questions remain regarding long-term effects of burosumab and its impact on outcomes which require ongoing study. I'm happy to take any questions, and these are my references, and this is today's event code. Yes, I can post the event code. 1 second. I'm going to type it into the chat. 1282978. As far as like, I think there's a question that says, how rare is this condition in Louisville? I don't have exact numbers, but I can tell you that in our metabolic bone clinic, we do have, I'd say at least a handful of patients who have hypophosphatemic rickets. And many of them are now treated with burosumab, and I've seen a lot of really incredible clinical improvements since starting burosumab. So a lot of, papers still say that in relatively mild, in children who have relatively mild disease, then it would be acceptable to continue conventional therapy. But in my, in my experience over the last several years, it's so hard to be adherent to conventional therapy. And so many of the kids just don't tolerate the phosphorus and have pretty significant GI distress. It's to me a no-brainer to just go ahead and treat with burosumab, irregardless. And like I said, I've seen a lot of really, really significant improvements clinically. Dr. Winter says, can you explain how the X-linked dominant mutation results in disease? So I'm not sure I'm 100% understanding your question, so I'm sorry about that. But I think essentially, I don't know if you're referring to my mentioning like gene dosage, which is something that we see fairly frequently in X-linked conditions, where if you have a female who, if you have a condition that's X-linked recessive, and you have a female carrier, they don't necessarily have disease, if you will, or they have a very mild phenotype. Whereas in the setting of XLH, which is X-linked dominant, even a hemizygous, if you have like a hemizygous male and a heterozygous female, they're all going to have the possibility of severe disease. I mean, it's just related to effects, mutations, preventing FGF cleavage and increasing the amount of FGF23 that's circulating. I'm not sure. Did that answer your question, Dr. Stephen or Dr. Winters? And I apologize because I can't hear anyone, so if somebody's speaking, I'm not hearing it. I don't know of any updates on gene therapy or cell therapy. If there's no other questions, then I'm gonna go ahead and end this meeting, but thank you all so much for having me.